Good afternoon, and welcome to this edition of Huntington's Disease and Physical Therapy. Today we're going to look at Module 4, Physical Therapy Management of Individuals in Late-Stage HD. This program is brought to you by the American Physical Therapy Association and HDSA. We'd like to thank APTA for their partnership in developing this course and for Broda Seating for their support of this module. Broda manufactures innovative, high-quality seating designed for long-term care. Their chairs provide unsurpassed comfort, positioning, and durability to provide the highest quality of life. Broda chairs are used in skilled nursing facilities and hospitals, as well as hospice and palliative care. For more information, please contact Broda at the website or the toll-free number listed below. Before we begin, I'm going to go over how to ask a question. Questions will be answered after the presentation. However, you may send a question at any time. To send a question, go to the control panel that appears on the right side of your screen, and there'll be a box for questions. Type in your question or questions and click on the send button. And don't forget to download the slides of today's presentation before the end of the broadcast. Ann Cluse is an investigator for the Ohio State University Mobility and Exercise in Neurodegenerative Disorders Research Lab, where she investigates physical therapy interventions to treat balance and mobility problems in individuals with Parkinson's and Huntington's diseases. Dr. Cluse received her physical therapy training at the University of Wisconsin and her doctorate from Cleveland State University. She's a neurologic certified specialist and has over 25 years of clinical experience, many of which have been spent working with patients with neurodegenerative diseases. She's a professor of health and rehabilitation sciences at The Ohio State University. Our second presenter, Teresa Berner, is an occupational therapist and the rehabilitation clinical manager at Wexner University Medical Center, where she has 22 years experience in seating and positioning. She is currently responsible for the Assistive Technology Center and outpatient rehab. She is adjunct faculty at the School of Allied Health at The Ohio State University and is involved in teaching both in the occupational and physical therapy departments. Teresa has participated in several presentations on seating and positioning and spinal cord injury in both the U.S. and Canada, as well as internationally. And now it's my pleasure to turn the broadcast over to Ann Cluse.
Hello, this is Ann Cluse, and welcome to our talk on physical therapy management of individuals in late-stage Huntington's disease. Neither Teresa Berner nor myself have any relationships to disclose or list. I'll be talking first about physical therapy interventions and caregiver training. Here's our objective. By the end of the presentation, we hope you will be able to describe common impairments in late-stage Huntington's disease and the impact they have on activity and participation. We'll also talk about therapy in late-stage Huntington's. We'll describe physical therapy assessments and interventions for managing individuals in late-stage Huntington's and identify common areas for caregiver training by physical therapists. Teresa will then describe seating and positioning options for people in late-stage Huntington's to maximize their comfort and function. This is an overview of late-stage Huntington's disease using the ICF model. So if you look here on the left, in this box, you have the body structure and function impairments that are very common in late stage. And that would be limited volitional control of limbs, and there's often trunk chorea and or rigidity. In later stages, individuals tend to become more Parkinsonian, and they become very rigid and akinetic. There will be limitations in passive range and motion that could be due to just lack of movement or maybe some dystonic posturing, which has caused contractures. Therapists need to be aware that there's a high risk for aspiration and respiratory infection due to swallowing problems and respiratory functional problems. Because of the immobility, the risk for pressure sores is much greater in late-stage Huntington's. People in late stages also will have difficulties or even be unable to communicate in late stage Huntington's due to dysarthria and eventually anarthria. Depression is often experienced by people in late stages. It may be related to anxiety or also just a decreased quality of life. And then finally, it is important to recognize that pain is experienced by many people in late stages, and you always want to ask about that. Pain could be from a variety of different things. It could be from just lack of movement. It might be just because of they accidentally are hitting themselves with the chorea, or it could be psychologic pain, just the stress and anxiety that they're feeling. And then to show you then how these are linked, the impairments then can cause problems with activity. And so you see here in this box different activity limitations that are common in late stage. The person will become unable to ambulate. They will become dependent for almost all of their ADLs. They also have a lot of difficulty maintaining an upright sitting position. And these activity limitations then will impact their participation and cause them to be dependent in functional areas. Along with that, as they lose their ability to move, they often become very socially isolated and withdrawn. There are personal factors and environmental factors that can have an impact on the severity of the impairments and activity limitations. For instance, personal factors could be the person's age or not they have other comorbidities. And another factor, personal factor, would be just how much physical and social activity do they have. Obviously, the more they have had will most likely be improved function for them. Environmental factors are things like their home environment. Is it an environment that really promotes them keeping themselves active or not? Also, we have social support. Later stages, it's because of apathy and other psychologic and cognitive problems, it's very hard to get people to be active, and so they need a lot of support. And the other thing, another factor, whether or not the healthcare providers are aware of how to manage people with Huntington's disease, that can make a difference. These are just some of the general physical therapy goals in late-stage Huntington's. As I was saying, many times in the late stage, people with Huntington's become very inactive, and this can really just accelerate a decline in their function. So we really want to try to promote as much activity as possible and maintain their optimal function. Because of their decreased mobility and the fact that they may be spending more time in bed, we want to minimize the risk of aspiration, respiratory infections, and bed sores. We also want to promote optimal comfort in their bed. And we always need to be thinking, because of the fact they can get contractures, that we want to maintain, or if they've lost range of motion, we want to increase their range of motion. And this is for their own comfort as well as for caregivers that are needing to manage their hygiene and care. We always definitely are wanting to support and educate nursing staff and caregivers about how best to assist patients in the later stages with mobility so that they can maintain their optimal function. And if necessary, if the person needs to get some external help, like home care services, or they need to relocate to a nursing home, we can help to provide support for that. Here are some late-stage assessments that therapists could consider using. On the left are body structure function impairment measures, One of them I'm going to mention here is the Unified Huntington's Disease Rating Scale Motor Subscale. This is a disease severity scale, and the motor scale has measures of involuntary as well as voluntary movements, as well as postural tasks and also gait. So it's a very important measure. These other areas that can be assessed would be looking for pressure sores, range of motion, manual muscle testing, and if you can't do manual muscle testing, just observing their spontaneous movement. Respiratory system evaluation is very important, and of course taking a fall history, because they will be at risk for falling. On the activity limitation assessments, here is a list of tests that have been actually found to be very reliable tests in late stage Huntington's disease, and this was a study by Quinn and colleagues. And if you look at these, there are some of these tests, like the 6-minute walk test, the Berg balance test, and the physical performance test that might be very difficult or hard for people with Huntington's in late stages to be able to do. So some alternatives might be to use like the postural assessment scale that's used for stroke, or the trunk impairment scale, or the functional sitting scale, which are scales that look more at like sitting and postural control for lower functioning individuals. Now these tests that I just mentioned have not actually been looked at and examined in people with Huntington's, but those are tests that you might consider using for people in late stages. On the intervention side then, what can we do to promote active movement? Because I said it's so important that they be encouraged in the late stages to engage in as much activity as possible so that their function doesn't decline. Ways that you can do that are having them walk with physical assistance or the use of assistive devices if they're able to walk. And if not, they can propel their wheelchair, sometimes using their legs. Standing is a great activity. Just standing with some sort of support, you might consider using a standing table and or just a table or counter that they can stand by. Sitting on the edge of the bed is another good activity because it helps them to use their postural muscles and helps with breathing. And that can be done with support as needed. If they're spending much time in bed, you can have them do active exercises in bed, like bridging or rolling, and that will help to prevent muscle wasting and skin breakdown. And then finally, you want to have them, and you definitely want to talk to caregivers about having the person perform as much as possible the activities of daily living that they can. That can be just putting their clothes on and off, or bathing, or brushing their teeth, even using like a TV remote controller. Anything that will keep them active is a good idea. The caregivers often want to help them, and you can understand because it may take people with Huntington's in late stages a lot longer to do something, but you do want to tell the caregivers that if they can be very patient and allow the person to do as much as they can themselves, it can really help them in the long run. Transfers will become difficult in late stage. They can be made easier by raising the seat height. You could put extensions on chair legs or use raised or elevated toilet seats. Another way to make transfers easier is to make the support surface firmer. Many individuals we talk to have difficulty getting up from soft couches or beds, and so you could have the caregiver perhaps buy some dense foam at some point, the person with late-stage Huntington is going to need help for transfers, and you're definitely going to want to teach caregivers how to assist the person with transfers. So you want to make sure that you recommend the use of gait belts. You also may have to give the caregivers some cues that they could use, because in particular, people in late-stage Huntington's tend to lean backward or fall backward when they're standing up or sitting down. So they may need some cues to keep themselves forward. It's also a good idea to use some sort of very simple, short command that helps the person to initiate the movement. So for instance, you can count and say 1, 2, 3, go, before you actually try to help them to stand up or sit down. And this can be very helpful just to get them going. And another thing is that if they have excessive chorea of the arms and it's impeding the person trying to help them to transfer, the person with Huntington's can just hug themselves, and that will often really minimize the amount of chorea and make transfers easier. At some stage, the person with late-stage Huntington's won't be able to stand for transfers. And so then you have to go to alternative techniques, which could be a sliding board or more likely using a transfer lift, such as a Hoyer lift. Here's a picture. You know, the first choice in terms of transfers is always going to be your standing pivot transfer, as long as they can stand. And when they need to, when they are not able to stand, then I would say go to the Hoyer lift and try that next. I don't know how well the sliding board transfers will work. I think that it could be very difficult for people in late stage to learn that, and so I think you should go to the Hoyer lift. If the person is able to walk at all with assistance, then you may want to consider using some type of assisted device with them in order to improve their walking safety. And we actually conducted in our lab a study in which we looked at the use of different types of assisted devices in people with Huntington's. Now, these people were in early to middle stages and not in the later stages of Huntington's. But in our study, we found that a 4-wheeled rollator walker, such as you see up here in the box on this slide, was the safest ambulatory device for the person with Huntington's to use compared to canes. And we looked at like standard canes and also weighted canes and other assistive devices. And those other assistive devices were a standard walker, a 2-wheeled walker, and a 3-wheeled walker. And just in general, we do not recommend using any of those other devices that we have just found, and this is from our experience as well, that individuals with Huntington's just do a lot better with the rollator walker in terms of their gait pattern is more normal, and also they're safer. Now, if a person cannot use one of those, cannot use the rollator walker, then you may consider using something called a PVC ambulator walker, or a Mary walker. And this can really be very successful. It's often used in nursing homes because of the fact the walkers are really large and they require open spaces. So they're really not as feasible for people to use in their home environments. But we've had many patients at our clinic who were in nursing homes that used these types of walkers with success. And that way it allowed them to be able to walk for a longer period of time. These are just some examples then of these types of ambulator walkers. A Mary walker is just a type of these PVC ambulator walker, but this is a type that we found to be commonly used in nursing homes. As a person needs physical support to be able to walk. It's a good idea to actually train the caregivers on how to help assist the person with walking. One thing that you want to tell the givers is to make sure that the person is wearing good, proper footwear. And ideally, you want the person to wear shoes, not sandals or flip-flops, that provide support, that have a low heel, and that have contact all the way around the foot. We also advise caregivers to use a gait belt. And you definitely want to make sure that you advise the caregivers not to pull the person up by their arm or under their arm because of the fact that it could lead to shoulder injuries. That's why using the gait belt is preferable. And typically we recommend to caregivers that they walk with the person at least 2 to 3 times per day until the person is mildly tired. As the person with Huntington's becomes less and less mobile, they may be spending more time in bed, and it's important to think about their positioning. You don't want them to get contractures or pressure sores. So there are things that you can do. As you see in this picture, you could utilize the pressure relieving mattresses or cushions such as you see here to make sure that they're properly positioned in bed. And then it is also important if they're not able to really move in bed or roll themselves, that you put them on some sort of a positioning schedule, which of course you would want to teach to their nursing staff and caregivers so that they don't lay in one position too long and get pressure sores. One thing you need to be aware of is that people with Huntington's in late stages often have problems with falling out of bed. And this is due to perhaps a variety of different reasons. It could be they have very severe chorea, and the chorea might be causing them to fall out of bed. Also, it might be due to decreased spatial awareness, where the sense of so that they don't sense where the edge of the bed is. Or it could be difficulties with force modulation, in which they just want to get out of bed, but they end up like vaulting out of the bed instead, and it sometimes causes them to fall down on the floor. So there's some possible solutions to make them safer in bed. You could perhaps try using padded bed rails. We often tell people to lower their bed height, and even like putting the mattress on the floor, as long as they can get up from the floor. And if those don't work, then you could go to a netted bed enclosure that fits over a hospital bed, or a last resort might be a Craig bed, and this is a picture here in the corner, upper right-hand corner of the slide of a Craig bed. As I've been talking to you about, people in late stages do become very immobile, and so of course they're at risk for losing range of motion and even getting contractures. And so it's very important that the caregiver knows how to perform range of motion exercises as needed. It's important to focus on moving their joints into extension and rotation, particularly, and if you think of their trunks, which is trunk motion is so important for a lot of key activities like sitting, reaching, stepping, and often their trunks become very flexed, and also because of all that rigidity in their trunks, they may lack rotation of the trunk. So you really want to focus on moving their joints into extension and rotation. And this can be done when the person's in bed or while seated in a supportive chair, to make sure that the person is able to maintain their balance while also attempting to move their own joints. Now, if they're not able to move their joints, or they can only move their joints through very small ranges, then that's when the caregiver should be instructed to provide either active assistive or passive range of motion exercises to their limbs. All individuals in late stages Huntington's are at risk for falling, and that can be, it could be from sitting in a chair, lying down, or when they're trying to stand or walk. So you may want to consider advising them to wear some sort of protective gear to help reduce and prevent injuries. So I have a picture in the right-hand corner here, upper right-hand corner, that shows you some of the things you might use. A soft helmet could help protect their head from cuts or abrasions. If they're falling and they tend to fall on their knees, then knee pads might be good. Elbow pads can be good if they have flailing limbs and they're hitting themselves and bumping their elbows on furniture. And then finally, if they are falling and they tend to land on their buttocks, you might consider using hip protector pads so that you minimize their risk of fractures. Respiratory dysfunction is always going to occur in late stages of Huntington's, and they will have impaired respiratory function and capacity. This will cause them to have limited endurance, and also their cough can become very ineffective, and they'll have impaired airway clearance, so they can't get all their secretions up, and that can also really restrict their functional activities, and of course it increases their risk of getting some types of infections and pneumonia. So as a therapist, you definitely want to do some type of respiratory system assessment. There are certain scales that you could use to look at breathlessness if they're getting short of breath or having breathlessness. You definitely want to listen to their lungs and observe their breathing. Look at the person's breathing to see if they're told to take a full breath, whether or not their stomach expands, to show that they're using their diaphragm, and whether or not they're using their neck or upper chest accessory muscles for breathing. You also want to check their cough and see if they are able to produce a forceful cough. You might even ask them to blow on some paper to see if they're able to move the piece of paper to get an idea of their expiratory force. And then also check their rib cage expansion when they inspire. If you put your hands on both sides of their ribs with your thumb in the middle and your fingers along their costal margin, you should see a separation of your thumbs by about 2 inches when the person breathes in. There are some other tests such as forced vital capacity, which I've written here, and peak cough flow, that are special tests that are usually done by respiratory therapists or physicians, but sometimes they are done by physical therapists. But it's a good idea to know what the normal and abnormal values are. So for forced vital capacity, which is basically a person takes a really deep inspiration and then blows out as fast and as hard as they can. And it's normally around 3 to 5 liters. So if it goes to half of that amount, about 1.5 liters, or less than 50% of the predicted value for their age and sex, then that is definitely indicative of respiratory weakness and perhaps impending respiratory failure. So you need to get them, definitely you want to have somebody evaluate their breathing more fully. Peak cough flow is normally around 360 to 840 liters per minute. When it goes below 270 liters per minute, the person is at risk of respiratory complications. And if it goes below 160 liters per minute, the person's going to have impairment. They're not going to be able to clear their airway. And that is definitely going to increase their risk for infection. So what can therapists do to help with breathing? Well, one way is, particularly if they're not getting good ventilation or there is breathlessness, shortness of breath, you can teach some different breathing patterns. One is diaphragmatic breathing. The therapist or the caregiver can put their hands on the person's abdomen and upper chest to give them some manual cues, and then ask the person to breathe in while focusing on expanding their abdomen into your hands. And the abdomen should rise more than the upper chest if they're doing the diaphragmatic breathing properly. Then once they breathe in, the person blows out slowly and just concentrates on letting the abdomen go down. Pursed lip breathing is another way to help them to breathe better. And with this, ideally the person with Huntington breathes in while keeping their mouth closed. This could be hard for some people in late stages to keep their mouth closed, so it's okay if they cannot. Just let them, breathe in as deep as they can, and then tell the person to blow out for 4 seconds through pursed lips. If a person has difficulty doing that, you might just tell the person, blow out as if you're trying to blow a candle out. Or tell the person to breathe out twice as long as they take time to breathe in. If their cough is ineffective, then it may be important to use airway clearance techniques, and of course you would want to educate the nursing staff and caregivers on how to use these techniques, because it can be very helpful in allowing them to get enough cough force so they can get secretions up. Here are some pictures showing different ways you can do manually assisted coughing techniques. In these pictures, the person is sitting, or you could have the person in supine as well. And typically the caregiver either stands behind them, as you see in the upper picture, or they could also stand in front of the person, and you see that they have their hands over the person's lower ribs or upper abdomen. As the person then with Huntington, first of all, they have to take a deep breath in, and then you ask them to cough. And as they attempt to cough, the caregiver pushes upwards and inwards, and that really will help to increase their cough force. It may take a little bit of practice, though. It isn't always really easy for the person to learn initially, but if they keep practicing, they usually can learn it. If these manually assisted coughing techniques are not enough to help them to get rid of their secretions, then you may suggest that they go to using a mechanical insufflator, exsufflator machine. These machines are very, very effective at increasing cough force and really help to get secretion. All right, I am going to now turn over the presentation to Teresa.
Go ahead and start talking just to make sure everyone can hear me. I'm going to send a message to our organizers. So my section is on considerations of seating and positioning with the Huntington's disease. And I just wanted to echo what Ann said, is that you really want to keep them active. Sometimes keeping them active when you're with them is not always the case when they're alone, and so there's occasionally times when you may use seating for intermittent or when really to keep them out of bed. So I'm going to go over, see if it's going to let me, it's not going to let me progress. Try this. I'm going to go over some of the funding guidelines, because funding isn't as easy as it used to be to get equipment, and I'm going to also go over some different frame options just to make sure that there's an understanding of what's available, and then talk a little bit about skin protection. So as far as guidelines for funding, in 2006 there's a lot of policy changes that were made. The biggest change is it's someone called an assistive technology professional, or ATP. What we recommend is required for anything that is group 3 or complex, and I'll explain that in a little bit, but it requires somebody with a special certification on the supplier side, because there's been recognition that equipment isn't all equal and the advanced equipment really needs somebody with the training. The other thing that started is the third bullet, which is competitive bid. So you have the higher end equipment that the ATP is involved in, and then you have the lower level equipment that's gone to this competitive bid program. When you're looking at the equipment, if you're not real sure where it falls into, the risk is if you end up getting something more simple when you needed something basic, or vice versa, you can block getting what you need in the future. So it's really important to try and understand the components of the equipment when we go through the eval, and my goal today is to give you at least a frame of reference and understand some of the options and equipment. Fourth bullet, in-home. So the in-home requirement is important because if somebody lives in a long-term care or skilled facility, they don't consider that in-home, they consider that facility. So Medicare would not fund specific equipment for an individual that's in a long-term care facility. They would require that facility to fund the equipment. If the person is in a home environment, then they want to look at how that equipment is helping the individual get around inside their home, essentially not for the community use. So again, I'll talk about that when it comes to some of the specifics. So moving forward, if you're unsure or you're not clear about what options you have, it's always great to find a seating clinic or find a specific expert in Huntington's disease, because we will always be a consult, guidance, we will be a reference for you, because we realize that we all can't be experts in the various areas of care that our patients need. The last caution is with all the funding. When we have a lot of direct sale companies that are trying to bypass the healthcare professionals, sometimes the needs of the consumer aren't always forefront. So it's just a caution to keep with your rehab team, with your medical team, and work collaboratively. So this paperwork trail shows you the new requirements. There's essentially 5 documents that are required when you need to get a piece of equipment. And this is what has changed, that you can't just put an order in. Unfortunately, if the physician wants X chair, they still need to follow up with all these components. This in itself is a separate lecture, but being aware that there's a lot of pieces and they all have to be timed in order for the individual to get the equipment appropriately. So now getting into the specifics, starting with manual wheelchairs for people with Huntington's disease. Definitely in the early stages, we want to keep their strength and conditioning, everything that Ann said, using the rollator walkers. We want to prevent falls. You know, you definitely start to see deficits in coordination and upper extremity and starting to see changes in their cognition. But it's really not until the middle to the late stages that you start thinking about what type of mobility equipment is needed. As the chorea worsens and you have the different movements, pushing a manual wheelchair with the arms and the coordination with the hands becomes really tricky. Walkers do become unsafe, and it doesn't mean you have to completely rule them out, but let's say if somebody is not with the individual and that person needs to get someplace by themselves, maybe just into you know, an area for using the restroom, or if you're in a skilled facility to the nurse's station, there's times when you're going to use a combination of maybe a walker when they have somebody with them, but if they do need a wheelchair, what we find for people with Huntington's disease is sometimes it becomes easier for them to actually foot propel rather than use their hands for coordination. So as we're talking about manual wheelchairs, these are the different type of wheelchairs that exist. So the top left is more of a standard wheelchair. The top right is your ultra high performance, ultra lightweight wheelchair. The one in the middle is one that I would ask you to consider and use because it's considered high strength. So the value of it being high strength, lightweight is it's going to be a little lighter to roll around than the chair on the top left. But what the chair in the middle does, it allows you to adjust to seat to floor height. So if you have somebody that's really difficult with transfers that Ann said and you need to get them a little bit higher, you can adjust this within the chair. If it's somebody that needs to be able to foot propel and you want to get a good heel strike, you can get them down lower with this type of chair. So when you break it into the Medicare terms, a chair is not just a chair. Manual wheelchairs have these type of codes, the K1, K2, K3. These refer to that chair in the top left corner. The K4 and K5 is really what differentiates a functional chair. So the chair that I showed you previously was the top right, the Ultra, the high performance chair, is going to be a chair that has a lot of adjustment in the wheel axle. But stepping down to a K4, the K4 is going to have a performance like a K5, but it's not going to have as much of the wheel axle adjustment. It's going to have the seat to floor adjustment. So if I go back, this middle chair is the K4, the chair to the top right is a K5, and the chair to the top left is a K1 through 3. Reason I say that is if you just order a wheelchair, that person may get delivered a chair that's on the top left, and if the physician signs off on that, and then they come across a therapist that says, oh my gosh, we need a high strength, which is a K4, the chair in the middle, we can't get it because somebody's already certified the chair on the top left is the chair that they need. So for the therapists that are on the call, if you can say high strength, lightweight, that's going to help assure you're going to get the proper seat to floor height for somebody that may be able to benefit from foot propelling. If you're not familiar with the foot propelling, if you look at the picture on the top left, we're looking at the distance between their axial, from their back of their knee to their foot, in order to allow for the right-hand side for them to have the heel strike. So when we measure them, if this is 18.5 and you think they're sitting on a cushion that's 2 inches, that's 20.5 seat to floor, that's going to be really hard to foot propel. So I would probably want to order a chair that is 16 inches seat to floor and then have the 2-inch cushion, which is 18. You often hear that with people that have strokes. It's called a hemi-height cushion because a lot of people that have strokes use their foot and their arm to propel, and the hemi-height manual wheelchair is where that comes from. So somebody that may not be safe to be by themselves with a rollator walker, but maybe wants to be mobile within their room, and we want to keep them from being bed confined, this may be an option for somebody needing to get around for safe propelling. So now you go to the real late stages of Huntington's disease, and you really want to look at safety. Anne already alluded to the falling. She already alluded to the movements and all the different components that you really need to be aware of. But you want to think about how can I keep them upright in this equipment so they're not bed confined, but they're safe and they're able to participate in more therapeutic environment, such as some of the different activities that she already mentioned about keeping them engaged. Being aware of positioning for long periods of time is something that we want to look at with their skin, and just making sure that they're able to be safe while they're upright. So that goes into positioning chairs. So we heard about Broda at the beginning. That is a common chair that's being used. And then if you want more, I would say not advanced, if you need more aggressive positioning, you can look at a tilt and space chair. So if the Broda chair is not meeting the needs because of maybe some specific added complications such as spasticity, or if there's some additional medical complications, you can look at something like a tilt and space. I don't tend to see the top right reclining wheelchairs. Reclining wheelchairs tend to be definitely more passive, and they don't have the position that you see is in the Broda chairs with the lateral movements for support. So when you're going to go through, and I'll try and go through this pretty quick, I wanted to just give some golden nuggets for seating. You really want to look at what your purpose for the seating is. Sometimes the seating is for postural controls. You just want to maintain their position and make sure that they're safe. Sometimes it's for pressure redistribution. So if the person really isn't moving, or they sit pretty symmetrical, but they just can't do pressure relief, because either physically or if cognitively they just aren't aware to move, then your seating is going to be for pressure redistribution. And then obviously seating for comfort. We want to make sure that while they're up in the chair, they're comfortable so that they're not trying to fight to get out of the equipment. So when you're going through your plan of attack, you want to look at that individual and you want to look and see if there's any asymmetries. Look at their current seating. What is their position of comfort? Do they lean to the left? Do they lean to the right? Do they tend to sit more midline? We always check it with supine so that we see with gravity out of the picture, are they flexible? You know, are they leaning to the left because they've developed some type of obliquity, or are they leaning to the left because they have pain and that's just a position of comfort? And then we'll test it with unsupported to see how can I get this person maximally comfortable. And so when you test it is where you correlate your asymmetries with your mat eval. And essentially, if you haven't found anything for a reason that the person should be leaning asymmetrical, you want to try and prevent them from maintaining that position. And then if you find a reason why they may be leaning to one side or the other, you want to accommodate it so that they don't end up creating more of the asymmetry and risk falling out of the chair. So when you're looking at seating, I thought these premises were really good, and I got this from a course that I went to, a physical therapist that does ride design. You know, you want to support non-destructive resting posture. When people are resting, they want to have a good pelvic control, you want to optimize spinal alignment, and you want to get good pressure relief. You want to give support to allow them to engage in activities, and so we talk about promote fine motor function without losing your core stability. And the third one is don't block transitions in and out of your movement. So oftentimes we get this perfect seated position, but then as soon as the person moves or goes to engage in a functional activity, they end up not being able to return to that position. So that's not good for any of us. These are just some pictures that are from Sunrise Medical. I thought they do a really good job of just describing the different postures and positions, and I'm hoping you can use this as just a resource for improving any documentation or quantifying words to what you see. So the next area is the sequence that we go through when we're doing a mat eval. We always want to look at the pelvis and lumbar spine. We want to find out, are they flexible into anterior or posterior pelvic tilt? Do they have any obliquities? Is there any rotation? And that's where we're going to look for some asymmetries. We then look at the hips and we look at their ability for flexion, abduction, adduction, external and internal rotation, and then we follow down to the knees, and we're going to be really careful at looking at hamstring length. Finally, the feet, we're going to look at dorsiflexion, plantar flexion, inversion, eversion. I find that if you can control the pelvis and hips, the knees and feet are going to tend to fall right into place, and you can support them with the either padding or the seating, as you saw in the earlier pictures. Once you get the lower extremity position, usually the trunk, shoulder, neck all fall into place. If you start with the trunk but forget about why the pelvis isn't there, then you end up fighting against each other. So start with a good proximal base of support with the pelvis, hips, knees, and then work your way up to the trunk. This picture is just a schematic of measurements. If you know you want a certain equipment, please take accurate seat width, seat depth, knee to heel for that seat to floor height, top of shoulder, and then the inferior angle of the scapula to the seat. So I thought this was a good reference to leave you with to get some real specific measurements to pass on when you're ordering your equipment. So the last section is skin protection. This came across a listserv that I was on. Somebody posed looking for cushions suitable for widespread use in facilities that provide some skin protection while meeting all the other facilities' needs, ease of use, cleaning, disinfecting, compliance with fire codes. We recognize that the facilities are often challenged with needing to provide a lot of different types of cushions, and their asset is if they can find something that has more of a universal need, then it can be more specific to the individuals. But the unfortunate thing is that when we really start to generalize solutions, sometimes we lose the importance of individual assessments. And so this, Carolyn Kelly from Canada, I asked her if I could use this quote, and the clinician in me agrees that yes, there may be a lot of equipment for wide facility use, but we need to make sure clients' needs are considered first and foremost. My caveat to that is I completely understand that there are limitations for skilled facilities. What I ask is just to look at what is being used and make sure the equipment match is appropriate for the individual needs, because sometimes there's resources. I call it my famous, closet, where we're kind of pouring through, and people might have mismatched equipment, and so we're maximizing the use. And then we do have somebody that has individualized needs. We're properly asking for that funding. So for skin protection, these are some pictures of some good pressure relief. I think individuals, until they get to the very end stage with Huntington's, because of the movements, and they probably, are able to move around a lot more without even realizing it. But once you get to the bottom right, if they get to that point where they're not able to independently move, then we need to assist them with the type of equipment and moving them throughout the day. So these are just some cushion options. The bottom left and right is not a terrible option. They would be used for somebody that is still mobile, and I would consider those more comfort. But the more traditional cushions that you see for skin protection are going to be a fluid cushion, which is the top left, an air-filled cushion, which is the middle, and then a honeycomb, which is the top right. Along with the different codes, just like I said, a wheelchair is not a wheelchair. The same thing with the cushions. I've given you the specific Medicare categories. So if you are asking for a skin protection cushion, you have to show that these two bullets are available. That goes back to that paperwork trail. When you ask for a certain piece of equipment, you have to have the medical justification, and then that creates that 5-step paperwork process. So you can look for yourself to see what specific categories are available. And then we have skin protection and positioning, and then we have customized. And I'm ending on power mobility because it's pretty well documented about the executive functioning that is impaired with individuals with Huntington's. We really eliminate driving very, very early, vehicle driving, because of the cognitive deficits. And there's a pretty good study that Davos in 2014 that looked at the impairments in Huntington's with executive functioning. So you correlate that to driving power mobility. It's really not safe. The movements make it difficult, but it's really the problem solving and the deficits in that person and being able to be aware of the safety of not only themselves or others. So try to get through that fast. Here's our references. I believe we do have time for questions. And I'll look to the side to see if there are any.
We currently don't have any questions, but as Teresa just said, we do have a few minutes, so if you do have a question for either Ann or Teresa, please send it to us. I did want to just talk with both of you, if I could, for a moment. I know that this particular module deals with physical therapy management in late-stage HD, but some of our participants in this module are new to the course, and can Ann or Teresa talk a little bit about the benefits of early intervention of physical therapy for persons who do have a diagnosis of Huntington's disease?
Sure. It's very important to try to get people intervene as early as possible in terms of physical therapy, even, pre-manifest if possible. If they know that they're at risk, you want to get people as optimally physically active as possible before they even start having symptoms. And once they start having symptoms, you definitely want to get them on some sort of regular exercise program to help them to be able to hopefully slow down the progression in terms of the decline in function. And we do know that exercise can help people to be functional for longer periods of time if you start it early. The other thing is, in terms of the using, in terms of using assistive devices and other types of equipment, it's best if you sort of introduce those in earlier stages, even sometimes when they might not necessarily need to use them. But just introducing the idea, number one, because a lot of people don't like to use assistive devices, and it might take them a while to kind of even accept that they might ever use it. And then the other thing is cognitively. You don't want them to get so advanced cognitively that they get to a point where they can't really learn very well how to use the devices correctly and safely. So if you introduce it earlier when there's less cognitive impairment, and you get them used to using it, it's more likely that it will be used by them, and that it'll be effective at actually helping them in the later stages to be able to maintain their walking.
Yeah, I echo that. I think that's really important, the learning piece of it, but also the acceptance of it. And I really like that slide that Ann had earlier about just keeping them active and having them, you know, a purpose and a role. Even if they can't do everything that they did, if they can maintain part of an activity or something that they were involved in, then that's going to give them the validation. The other thing I wanted to just add to what Ann said is this driving piece. If there are any OTs on the phone and on the call, really look at that article that I referenced. These people should not be driving, and so I think they need to hear it from multiple people multiple times, even when, you know, they're very early, so they can start planning alternate forms of transportation.
We do actually have a question here. Are there any weighted cane options available that you recommend for walking, or is it not practical and the four-wheeled walker should be encouraged instead?
That's a great question, because we actually did, in this study that we conducted, we did try using like a weighted cane, because it has been, you know, they say in the literature that it is supposed to, you know, be easier for the person to use and that it might, you know, help them. And actually we found no benefit. And we don't, in general, people when they use the canes, and these were people that weren't in the late stages, they were in early to middle stages that were in our study, they basically would basically just hold the canes and really never properly used them. Even after they'd been trained and we showed them how to do it, when they actually, we asked them actually to walk with it, they tended not to use it, or it tended to make their gait pattern worse if they did use it. So we don't recommend canes. And it didn't have any benefit over just a regular straight cane to have one that was weighted.
All right, we'll give everyone just a few more seconds. I did just want to ask you, because you do recommend a four-wheeled walker or rollator, Medicare doesn't actually pay for that, so what kind of documentation is needed in order to get that paid for through Medicare or your insurance company?
And I could touch base on that, if that's okay. So the issue is that the rollator walker falls under competitive bid. So the competitive bid is a set price point that Medicare determines for a wide range of equipment. So the rollator walker can sometimes cost more than a traditional walker, which means that the person dispensing it isn't going to make as much money off of that product. So then they say it is not covered, where the real aspect is they're not receiving enough payment for it to be worth their time. So we have one supplier that we've identified in Columbus that will dispense them for the price that they receive, and we're just keeping our fingers crossed that we'll be continually able to use them. And so as far as the justification, you need to just justify that they're unable to use canes and crutches and they're not safe to ambulate without it, and really emphasize the fall risk and the injury that would occur if they didn't have the equipment. And then it's always helpful to make a statement they're not yet needing to use a manual wheelchair. So you've ruled out below and you've ruled out above it to justify why they need that set piece of equipment.
Okay, great. We do have another question. are there any thoughts or cues you use for patients who are having paretic movements with sudden backward leaning or thrusting?
Well, I mean, I think you could use, you can use like maybe some manual cues to try to get them to be more forward. Possibly cueing too. Okay, one thing that we have, a person might be able to do this. It's basically, one thing that we found could be really helpful, say getting up or down, is to have them put their hands like on their thighs, and when they get up, put their hands on their knees, and when they stand up, they basically slide their hands up their thighs as they're standing up. And then when they sit down, they do the opposite. They have their hands on their thighs and they slide them towards their knees. And what that does, it works pretty good, and it makes the person be more forward bent when they're doing the transfer. So hands on knees, slide them up your thighs to stand up, and the opposite going down. And that, I would try that as one way to kind of cue them.
Okay. Well, that's really great. We are just about out of time now, so I do just want to thank both Ann and Teresa for this really informative webinar today. And we want to thank all of you who have been attending for your presence today. To attain your certificate of completion for this module, please go to hdsa.org/PT4 module test to access the post-test assessment and registration for your certificate. And you must score at least 75% on the post-test to be eligible for CEU, and you must complete the certificate information so we can send you the certificate. If you have any questions, my email is on there. And we invite you to join us on August 9th at noon for our final module, which are reimbursement issues. And to register for that, you can go to hdsa.org/PTCEU and click on the link for Module 5. Finally, for those of you who have missed our earlier presentations, you can access them by going to the different hyperlinks that are shown below. If you are unable to copy all of these because they are all a little bit different, you can email me at dlavecchi@hdsa.org, and I'll send you all of these different links. Thank you so much for your time and attention, and have a great day.